Welcome to Capnography For EMS.com, your source for EMS education for capnography and anything related. I'm your host, John Seiberth. For EMS, by EMS, that's what we're here for. We're going to get started today, and we're going to talk about VQ mismatch. Now, VQ mismatch is one of the causes of hypoxemia. Hypoxemia meaning lack of oxygen in the arterial blood. Okay, so when we're measuring that pulse ox, VQ mismatch is a source of that problem. And we may talk another time about hypoxemia because it really does play into this. But most of the people who are pulmonologists and such like that, they will tell you that if you can learn VQ mismatch and understand it thoroughly, then you know how the lungs work. And I would say the same thing applies with capnography. If you can understand and comprehend VQ mismatch, it'll take you a long way into understanding how your patient is presenting and what you can do to help them in a quick and efficient manner. Just as we start out every session, let's cover the basics. Capnography, the vital sign of ventilation. We're tracking carbon dioxide in a patient's exhale breath, and we're objectively evaluating the patient's ventilatory status, indirectly evaluating circulatory metabolic status. All three must be present for carbon dioxide production, and we are assisting ourselves with clinical judgment to assess and treat our patients. VQ mismatch really plays into this slide here today because VQ, meaning V, is ventilatory, and Q actually means circulatory. And in a way, we can still indirectly determine a VQ mismatch in relation to what the metabolic status is as well. Now, we're not doing math and science so much as we're using clinical judgment regarding VQ mismatch. When patients get upstairs and they're in intensive care, there might be a little bit more work regarding VQ mismatch, but there's still an application for us to use clinical judgment just like we do with a lot of the things that we do to treat our patients. Okay, so VQ ratio is what we consider the standard ratio for the amount of air cycling in and out of the lungs over the course of time versus the amount of blood circulating throughout the body to the lungs at the same time. So when we're thinking of a VQ ratio, what we want to think about is the amount of air and the amount of blood kind of interconnecting and moving through the alveoli at the lung level. So especially when we're thinking of perfusion, while perfusion status may be indicative of what's going on in the body, we want to think in our minds of what's going on at the end result of where that oxygen and carbon dioxide is being picked up and dropped off. So that's going to be really important for us to completely understand VQ mismatch and how it applies to our patient presentation. So what you see here is a standard VQ ratio, and I have the 4 liters of oxygen cycling into the lungs as a ratio compared to the 5 liters of blood that's circulating throughout the body and coming back towards the lungs. Okay, this is a typical VQ ratio of 0.8, though some people say that a typical VQ ratio is 1 because what we need to think about is up high we don't have as much blood supply. Okay, so we have a decrease in blood, and that's just simply because of gravity. And then down low we have an increase in blood, same reason, because of gravity. Okay, and that changes as we lay down or sit up or what have you. The same goes for ventilation. Okay, we have an increase in ventilation here, and because there's so much blood supply, we have a decrease in ventilation down at the bottom of the lungs. Now, what's interesting to think about is in order to have a good transfer of oxygen and carbon dioxide with respiratory status, we need to have both good ventilation but also good perfusion. So ventilation and perfusion actually need to act together. So even though we may have more oxygen or air up top, actually the best place for gas transfer is probably a little more towards the lower part of the lungs. maybe not all the way down the bases, but definitely not up high either. Okay, so it's kind of a misnomer to think that you have better ventilation to the upper part of the lungs, because the actual gas transfer needs to happen where there's a decent amount of blood too. Now, if we have too much blood in the lower part of the lungs, then we're going to actually prevent ventilation from occurring, because those alveoli are just being overcrowded with blood volume, to where we have too much perfusion moving higher up into the lungs. So once again, the typical VQ ratio is 0.8. We have 4 liters versus 5 liters of air versus blood circulating throughout the body. Okay, or at the level of the lungs, we should say. And if we think about things, I just said that we have the majority of our gas transfer somewhere in the lower part of the lungs. Okay, so we have O2 going in at the best area here, and then going out we have CO2 going out. Okay, that's also important to remember when we're looking at our waveform analysis with our patients, because remember, down here is where all of our alveolar rich carbon dioxide is coming out. And if we think about our waveform, well, we have our waveform here. This is the area where we're measuring our carbon dioxide, okay? Whereas this area here and this area here is where we're measuring our upslope of carbon dioxide. So we have to think about the lung in a whole as this total mixing, and this ratio is a total mixing of all of the lung. Okay, so that ratio, like I said, could be about 0.8 to 1 depending who you talk to, but it's important to remember that that this gas can mix throughout the lungs, and that mixing, that waveform that we have here, is a result of somewhat of that mixing. If we have impedance to that mixing, say we have some bronchioles that are plugged in certain spots, then we may have some distortion of our waveform that may not be completely normal. So we might have just a little bit of rounding or something on our waveform. Or if we have complete restriction, like say bronchoconstriction of the bronchioles down deep, right where this gas transfer is happening, then we're going to start getting a sloped waveform, right? Okay. So VQ ratio really plays into how we think about how our waveform is going to look, but also how the lung is functioning, both ventilation-wise and perfusion-wise. So a normal VQ is essentially normal respirations, a normal carbon dioxide exhalation, or you can also look at this as perfusion, of course, which is the actual term, but I like to think of it as normal exhaled carbon dioxide. If we're exhaling the proper amount of carbon dioxide, then we can generally figure that ventilation here is normal, and then we can also figure that perfusion is normal. And if we don't have any other abnormalities, say an increase in carbon dioxide where we feel that perfusion status is actually good, then we can generally assume that for our purposes metabolism is probably relatively normal as well. Okay, so a normal VQ is basically reflective of what is normal status for the body. Okay, now we get into what's called the VQ mismatch. A VQ mismatch is anything that can cause ventilations to be abnormal. So in this case, you may have, instead of 4 liters of air that the body's bringing in, you can have 5 liters. Okay, so now that there's 5 liters coming in, we may still have 5 liters of blood on its own. So we have a ventilation heavy VQ mismatch. Okay, or we may have a situation where we have decrease in pulmonary perfusion, and we may end up going down to 4 liters. Okay, so now we have an increase in ventilation to 5 liters, but we also have a mismatch on the perfusion side as well. So it can go either way as far as a VQ mismatch goes. You can have one or both. Okay. One of the most simplest ways we can look at a VQ mismatch is simple hyperventilation. And when we have an increase in respirations, we are also increasing the amount of air circulating in the lungs. Okay, so we're bringing in more oxygen when we're hyperventilating. So now we might be at 5 or 6 liters. And then the byproduct of that is that the body is blowing off more carbon dioxide. The perfusion status may not have changed, but we are blowing off an abnormal amount of carbon dioxide. And remember when we were discussing the amount of how gas transfer works at the alveoli, the body, do our lungs here real quick. Beautiful lungs once again, and the body brings in the CO2 rich blood back from the body, okay, pumped from the heart to the lungs, and then going from the lungs back to the heart and then to the body is all of our good arterial oxygen. So we've got the O2 here, and then we've got the CO2 here. And remember that carbon dioxide in the blood may be 45 millimeters of mercury. And then normally when it's blown off up here, our end tidal might be 40 millimeters of mercury. And then over here, we still have 40 millimeters of mercury circulating. Okay. Now, when someone's hyperventilating, as easy as it seems, sometimes we need to understand the most basic concepts before we can move on, okay? Since we're hyperventilating, we're dropping off more than our typical 5 millimeters of mercury on a repetitive cycle, okay? So if we're dropping off 5 millimeters of mercury for every breath or what have you, now we may be dropping off 7 to 10. Okay, and as we're blowing that off, remember end tidal CO2 is a direct reflection of what's going on in the circulatory system. Okay, so now instead of 45 millimeters of mercury being over here, maybe now we have 40 millimeters of mercury. Okay, and now that we have 40 millimeters of mercury, maybe this drops down to 35 millimeters of mercury. That's pretty ugly, but hopefully you get the point. Okay, and as that drops down, then this is going to drop down also to 35 millimeters of mercury. And that's going to be a perpetual cycle so long as a person is hyperventilating. And what we end up seeing is our waveform going from being nice, 35 to 40 millimeters of mercury to getting ever so low until the patient corrects this problem, if they do correct it early enough by slowing their breathing down. However, what ends up happening with a hyperventilation patient is that they drop their carbon dioxide so much that their body now is trying to adjust metabolically for that. So once a patient gets to a certain point where their carbon dioxide is exceedingly low, less than 20 millimeters of mercury usually, and sometimes as far as 10 to 15 millimeters of mercury, that patient's body can now not adequately compensate for that decrease in carbon dioxide, and now the body is going to be looking for ulterior motives or methods to increase carbon dioxide. So the patient just can't stop breathing because that's the only thing they can do is decrease respirations. But it gets at such a bad point that now metabolically the patient has to take over. And the opposite of that, I don't want to get ahead of ourselves, but this is respiratory alkalosis here. Okay, alkalosis meaning a decrease in carbon dioxide. So respiratory alkalosis is that, and then the body does the exact opposite of that metabolically. So then it tries to overcompensate by creating metabolic acidosis. That again is a whole other subject matter that maybe we'll cover another time as well. Now with VQ mismatch, we can also have just the opposite of what we just saw. Just the opposite, it would be a decrease in ventilation or an increase in pulmonary perfusion. So we may have a decrease in ventilation and or an increase in pulmonary perfusion. Now you don't necessarily need to have both, right? But it's very possible that you could have one or the other, or you could have both. Now this one seemingly is a little bit more difficult to understand. All right, we can have something very simple, such as the decrease in ventilation. Okay, the typical hypoventilation patient. However, we can also have a situation where, remember, ventilation is not necessarily just respiratory rate. Okay, so it's respiratory rate, but it's also tidal volume. And so technically speaking, we can have a decrease in ventilation if our tidal volume is off and or if our respiratory rate is down. Okay, we may actually have a time where our respiratory rate is up, but our tidal volume is down. Okay, one thing that I can think of, which has kind of come full circle for me with trying to understand and comprehend, is CHF. Okay, congestive heart failure. If we have a patient that's congestive heart failure, the typical congestive heart failure is left-sided ventricular failure, right? So the body is having trouble with stroke volume and dealing with preload going out to the body and circulating blood. So then we have blood and fluid backing up into the lungs. And if we thought about those lungs before, and I wish I took a picture of it, I don't know if I can. We'll just we'll deal with my ugly illustrations again. Remember that we said that the majority of perfusion and ventilation for our VQ ratio actually happens somewhere around here. Okay, there's my scientific schematic. So if that's where the normal amount of ventilation perfusion happens, then this is where all the gas transfer occurs. However, if we have a CHF patient, this area actually gets pushed up because now we have all this other fluid backing up into the lungs, and what we're doing is we're causing a abnormality as far as gas exchange goes. Now, it's important to know that carbon dioxide does transfer through fluids adequately. Okay, so when we have a CHF type patient, carbon dioxide actually does transfer completely through this fluid and out of the lung. Now, the important thing to remember is oxygen may not be able to do so. Okay, so you may have a hypoxemic patient in CHF, but you actually have normal carbon dioxide levels. And the best that I can tell, it should be about virtually impossible not to have at least normal or semi-low carbon dioxide levels with a CHF patient, depending on how soon you get to them in the event. But typically you're going to have normal to high carbon dioxide levels, but you're also going to have a decrease in ventilation because of that gas transfer problem, and you have so much perfusion occurring that now your best area for ventilation might be up here. Okay. However, Tidal volume is now down with a CHF patient because their lungs can't expand anymore. Okay, their lungs can't expand as well as they used to, and they're struggling to breathe. And as that happens, the patient's pulmonary perfusion actually does increase. All right. Pulmonary perfusion increases and ventilation actually decreases. This type of understanding may be a little bit difficult for some of us to grasp in the beginning. VQ mismatch is probably one of the toughest things that I ever had to learn regarding capnography, but it's probably one of the most fruitful areas of information that I've learned that has aided me to provide better differential diagnosis of the patient. And later on, when we get into case studies in our different episodes, I think that this will help put everything together. Okay, so as compared to that illustration where I went into a little bit more detail than expected with CHF, that same VQ mismatch we can look at very basically as hypoventilation. Okay, we have a decrease in respirations. Maybe the person is sedated or drunk or had a seizure. They may have a decrease in respirations and an increase in CO2. Okay, you may have an increase in carbon dioxide production because it's just the opposite of what happened when we were cycling off all of that carbon dioxide coming back to the lungs. We are now decreasing our ventilations either by respiratory rate or volume, and what happens is we have decrease in alveolar ventilation. Okay, there's not as much gas transfer happening down at the level of the alveoli. Instead of the typical 4 liters, okay, now we're going down to 3 liters. If we decrease in 3 liters, where carbon dioxide level was 40, and now we're going to 50 plus millimeters of mercury. Okay. Now remember, there was 3 things that I said, and I say in every one of our editions here, is ventilation, perfusion, metabolism. Okay, all 3 can be present at any time, or must be present for carbon dioxide production, but any one of the 3 or all 3, or any combination of the 3 can cause some type of abnormality with your carbon dioxide reading. So even though VQ mismatch mainly implies that there's a ventilation perfusion mismatch, you may actually have a metabolic mismatch along the lines too. Now, we're not going to know exactly for sure whether there's some kind of metabolic issue until blood gases are drawn at the hospital, but we can use our reasonable judgment and suspicions just as we always have. Capnography is just helping us narrow in a little bit more on that. So, simultaneous VQ mismatch, we may have that increase in respirations, and a respiratory rate may be 20, which is actually an increase, okay, or it may be 35. And then we have a decrease in carbon dioxide, and this is where we need to use a little bit of judgment to what's going on with the patient. So we may have a decrease in carbon dioxide because of some type of perfusion issue, okay? And then we may also have a decrease in carbon dioxide, again, because of a perfusion issue. It could be a really bad perfusion issue, so your carbon dioxide levels are really low, or you may have some type of metabolic issue. Okay. Now, what's one condition where this could possibly be going on? Well, how about DKA? Diabetic ketoacidosis. You have a metabolic acidosis, and in this process you have an increase in respirations, which actually further decreases carbon dioxide production, okay, because the body is now trying to blow off that additional acid, even though the body can't blow off the acid that's being created by the ketoacidosis, and in turn is blowing off carbon dioxide as a method of last resort compensation, which actually just perpetuates the situation. And then we also have a DKA patient where they've been pissing off all of their sugars, trying to control that sugar level. So when they did that, they actually depleted their volume, and their perfusion status gets worsening over the course of time. And then, of course, the part of the acidosis is right here, where the patient now has all these acids in their body, and now they need to get rid of them. And the only place to get rid of those types of acids is through the kidneys. But we have a decrease in perfusion, which then further perpetuates the metabolic issue as well. And also to the contrary, we can have a simultaneous VQ mismatch in the opposite direction, okay? We can have that decrease in respirations for whatever reason, and then we can also have the increase in carbon dioxide. Okay, so the patient may have a decrease in LOC, and so their respirations are down, and then they may actually have an increase in carbon dioxide production simply from the decrease in LOC. So they're going to be hypoventilating and increasing carbon dioxide production, and then they may also have a fever. Well, metabolism can produce additional carbon dioxide. So if the patient has a fever, their body is working extra hard to get rid of that infection or whatever else is going on. And in the early stages where a fever is present, you can actually have an increase in carbon dioxide that is noticeable on your end tidal CO2. As the process advances, that may not be as easily available or readily noticeable, but there are things that we can look at with the patient with regards to respiratory and ventilatory status and perfusion status that can help us navigate our way through those types of patients, but also provide better care. So then we can also have something I call a dual VQ mismatch. We may actually have normal respirations with certain types of patients, or seemingly normal, and we still have some type of decrease in carbon dioxide. So our end tidal CO2 is actually decreased. Let's say it's around 15 to 20, but our respirations are actually normal. And this is obviously counterintuitive, because when we see something like this, we have to try to determine what may be causing the underlying problem. So we may have a patient with nausea, vomiting, and diarrhea. We may have some patient with sepsis. We may have a wide variety of different issues, but oftentimes we're going to see those the most. We may actually see that with some type of arrhythmia. So if a patient has an arrhythmia and they may have a normal respiratory rate, but their perfusion status is really low because their heart is not circulating blood as it normally should. Okay, so one example would be a circulatory metabolic, but you could have a variety of issues that would cause a profound drop in carbon dioxide and still have normal end tidal levels. These ones are actually the easiest to detect a problem with the VQ mismatch, because you know that your ventilations are controlled. When a patient has a respiratory rate of 20 to 25, I can still feel reasonably secure in knowing that their end tidal should not be 15 to 20. It may be slightly low under normal circumstances, but when we have a profound drop in circulatory status based on our end tidal readings, which may also include metabolic status as well, I can feel reasonably secure in knowing that we have some type of circulatory and or metabolic status that's interfering with the ability for the patient to function normally. So to further complicate things for you, you can actually have a dual VQ mismatch, which in essence are dueling, so to speak. You may actually have normal respirations, and then what you actually have here is, because you have a decrease in circulatory status, let's say you have that sepsis type patient, and they are low on volume due to a variety of situations within the body and how sepsis is happening. Sepsis is a profound infection. But let's say they also have a fever. Okay, Well, fever, as we mentioned earlier, has an increase in metabolic carbon dioxide production. So as metabolism, remember metabolism is what produces carbon dioxide. If we have an increase in metabolism itself, then it will increase carbon dioxide production. Now you may actually have a very, very sick patient who has a respiratory rate of 18 to 20, which is technically a little high, or you could even have it lower. Okay, it could be 12. And you can actually have a end-tidal reading of 35, or maybe even 30. So even with a end-tidal of 30 with a respiratory rate of 18 to 20, we wouldn't normally think much about that. Respiratory rate's a little high, end-tidal level's a little low, not that big of a deal. But if we're assessing our patient in its entirety, and we're looking at all of our different signs and utilizing capnography as part of our assessment in conjunction with it, then we may actually come to the conclusion that, all right, this respiratory rate's slightly high. The end-tidal is maybe it's actually a little high for the respiratory rate to begin with. So you may actually have kind of a masking of what the underlying status is with carbon dioxide production, because you have that decrease in perfusion, but then you have the increase in carbon dioxide production that's aiding and masking what's really going on deep down inside of the body. Now when we put this all together with our systematic implementation of capnography, we're obviously going to be utilizing this with our entire assessment, like I just said. I just stressed the importance of that in the last slide there. So when we first get to our patient, we have to determine, are they sick, are they not sick? Well, I'm telling you right now, do not subjectively look at these patients and go, they don't look sick or they don't look that bad. A huge proportion of your patients will not look critical. Okay? They're not going to look critical and they're not going to look sick, and that's one of the biggest things that I've learned over the course of time, and why we decided to essentially provide capnography filter lines for any patient who received oxygen. So if a patient was getting a cannula, they got a capnography cannula, and their standard 50-cent cannulas went out the door. Just simply because, remember, our end-tidal CO2 is a vital sign. So you may have a patient that has seemingly normal vital signs, and the only thing that's going to necessarily be off is the end-tidal CO2. And if you just look at that patient and say, they don't look that bad, they don't need one of these cannulas, we'll just give them the 50-cent one instead, I guarantee you, you are going to miss something with that patient. Not 100% of the time, but I guarantee you, more than not, you will miss something. You might have something very subtle going on with this patient, and they may have a very slight change in mentation. Okay? Or maybe their blood sugar is increased, their blood glucose is increased, and there's no just cause for it. All those different things may come into play, and it's amazing how often we miss something like the change in mentation of a patient. Just because they don't have altered mental status that we can easily pick up on, is this patient acting any differently based on what their baseline is for family and friends, people that know them well. So based on my practical experience, I would say don't take that subjective evaluation of that patient too heavily into your decision to place an end-tidal capnography cannula on that patient. Okay, and then of course if you have an unconscious person, then I think we know what we need to do depending on whether we need to bag them or provide non-invasive measuring. So then we move on to waveform analysis. Okay, we evaluate our waveform. Okay, is the waveform a nice shape? Is it normal looking? Is it high in elevation, low, or is it normal in elevation? What's our rate? What's our regularity? Okay, that helps us determine our respiratory status, which includes tidal volume, and it also helps us include respiratory rate, which both are very important for our respiratory status, as we've said multiple times. And now we're getting to evaluating the numbers. This is really where our VQ ratio comes into play, which we've been talking about today. When we evaluate the numbers, are they high, are they low, are they normal? Are they maintaining steady, or are they trending up and down very quickly, which may give us an indication that we're getting poor readings? But if we have a relatively consistent end tidal level, then say it's at 20 and it's consistently like that, then we need to be suspicious that there's something going wrong, and we need to come down, get down to the bottom of it and figure out what's going on. Okay, so try to determine the VQ ratio the best we can with our clinical judgment, and determine not necessarily what exactly it is. In other words, is the VQ ratio 0.8 or 1.2 or 0.6? Okay, we're not worried so much about that. What we are worried about is understanding physiologically what's going on with the body and what can I do to help. Okay, as we go on, we would evaluate our changes in the trends. Okay, easy things to change with trends is patients that are hypercarbic that need additional ventilation, assisted ventilation. We may provide bag valve mask or a vent via mask, and we may ventilate them and reduce the carbon dioxide levels by increasing the respiratory rate and volume. Okay, that would be evaluating the trends and changes on the simplest of levels. And then the opposite is true too. If we have a patient that say is bleeding out or has some type of critical illness, we may be evaluating the trends to determine if we're at least keeping the patient where they're at, or if they're getting worse based on decreasing end tidal levels. So as I was learning capnography years ago, and I was looking and pouring through all this different information, different studies, and everything else that's related to this process for me, one thing that I came to understand is that there was very difficult for me to just kind of eyeball what was going on with a patient and not have some type of reference to help me better comprehend and understand what's going on. So I came up with this quick reference chart, and this quick reference chart was a way for me and some of our guys to reference what may be going on with this patient. Now, it's not all inclusive and it's not perfect because our end tidal readings are somewhat dynamic. Okay, there's a lot of things going on, and we have to, especially when it comes to VQ mismatch, we have to utilize great clinical judgment. So this is not the end all be all, but it does help me, and I think it does help other people, and I think it will help you to better utilize capnography in a way that's going to be more purposeful, in a way that's going to help you understand what to do for your patient, or what's going on with the patient, that's going to further propel you into a better level of care in the future. So starting at the top here, we have our normal levels, 35 to 45 millimeters of mercury, and just as we've been explaining to you, we evaluate the waveform, we evaluate the carbon dioxide levels, and then we evaluate that waveform trend and the levels actually as well. Okay, now I have this broken down into 4 different quadrants. We have decreased respirations and higher CO2. Okay, so the most basic of that would be hypoventilation, right? And then we also have decreased respirations and lower CO2. So the increase in respirations is actually on this side here, and the decrease in CO2 is on this side here, and of course they intermix as well. Okay, we have decreased respirations up top and then increased respirations down low as well. So let's get this cleared out real quick. Alright, so as we move along, there's one quadrant that tends to be the most utilized and that you'll most often see, and that one is our increased respirations and lower CO2. So, if we have an increase in respirations and lower CO2, well, very easily that could just be a simple hyperventilation, okay? That goes without saying. But what else could be going on with the patient? So, if we have an increase in respirations and lower CO2, well, it could be an asthma attack that's early on and early to moderate, okay? But if we have an asthma attack with increased respirations and lower CO2, then we should expect our waveform would also be sloping, okay? But what happens if we have a normal waveform and we have a respiratory patient that we're suspecting? Well, in this case, we can rule out, most likely with a good assessment, we can rule out this asthma or COPD if we have a normal waveform. Okay, then that leads us to the next area. Okay, could it be pulmonary edema or could it be acute respiratory distress syndrome? Well, pulmonary edema, let's just say that's closer to the CHF role. Okay, it can be a slight difference, but let's say we're thinking CHF. Well, I'd already mentioned earlier that with CHF, you're not going to have a dramatically low carbon dioxide level, but it might be slightly low, say 30 to 35 early on in an event. But for the most part, we're not going to have that issue. Now, acute respiratory distress syndrome. That's an interesting one because I've seen many of patients that present like they're CHF. We may not have very good lung sounds. We may actually feel that we have pulmonary edema with an acute respiratory distress syndrome, and they have a huge, profound decrease in SpO2. They will have a normal waveform, and like I said, just like a CHF patient that would have a normal waveform, that's our true differential diagnosis between CHF and COPD, by the way, is normal versus abnormal waveform. But in acute respiratory distress syndrome, one of the clear-cut things that we're going to notice differently between CHF and ARDS, which will make a huge difference in how we treat our patients, is a profound decrease in end-tidal CO2. Okay? If we have a profound decrease in end-tidal CO2, and I'm talking like 20 millimeters of mercury, okay, that's going to be a clear indicator that there's very poor gas exchange at the lungs, which could indicate a perfusion issue also, but most likely there's some kind of problem with gas transfer in that typical ARDS patient who otherwise is going to be presenting as a CHF patient. Okay, that's going to make a huge difference how we treat that patient, because if we start hitting an ARDS patient with nitro and captopril and everything else trying to reduce blood pressure, we're actually making that gas exchange worse because we're reducing the perfusion status of the patient further. Okay, so that kind of takes care of our respiratory emergencies. Whoops, sorry about that. All right, so then we also can break this each quadrant down into hypoperfusion status and then metabolic status as well. Okay, so hyperperfusion states, we can have anaphylactic reactions. We can have sepsis to septic shock, severe sepsis to septic shock, which is also probably a whole other talk on its own. And then also hypovolemic states. Do we have dehydration or hemorrhage? How about a right-sided MI with posterior involvement? Okay, another great case of where we have a preload dependent patient who has a decrease in pulmonary perfusion coming from the right side of the heart. If the right side of the heart is dysfunctioning or not functioning well, then it would go to say that carbon dioxide return to the lungs from the right side of the heart would also be decreased. Okay, another great tool for capnography with MIs, or maybe even undetected posterior wall MIs as well. Okay, tension pneumos, pulmonary emboli, cardiac tamponade, not always very easy to detect even with capnography, but obviously tension pneumo, our main indicator is a decrease in lung sounds on one side, but we may have a profound decrease in carbon dioxide with it. Pulmonary embolism, if we think about pulmonary embolism, we can think about areas of an area of the lung being completely blocked with perfusion. So even though there's ventilation to the area, we're not transferring any gas to that area. So therefore, with a severe pulmonary embolism, we'll have a severe decrease or completely absent amount of carbon dioxide exhaling from the lungs, depending on how the extent of the pulmonary embolism is. That we may also discuss in a later time. And then cardiac tamponade, very difficult to tell, but there is some literature that discusses that. Now, it's important to remember that with most of these, you will have a normal waveform still. The caveat to that is our anaphylactic reactions. Now, remember, anaphylactic reactions may or may not have respiratory involvement as far as a bronchoconstriction. It is very important to remember that just because an anaphylactic reaction has a normal waveform does not mean that they're not having an anaphylactic reaction. What do I mean by that? Well, typically we think of an anaphylactic reaction as having this bronchospasm, okay? That is very possible, but they may not be present or may only be slightly present, and we may have a patient that is presenting like an anxiety attack, but they also may have a ever decreasing end-tidal CO2. So they may have an increase in respiratory rate, and then they may also have a decrease in CO2 that may present as a typical hyperventilation. But what's happening here is we have such a profound decrease in perfusion due to the anaphylactic reaction and distributive shock that we will have a decrease in the return of carbon dioxide to the body. To the lungs. Okay, once again, a decrease in pulmonary perfusion. So these types of patients may or may not have a distorted waveform due to bronchoconstriction or bronchospasm, but they will most notably have a severe decrease in carbon dioxide production, which further warns us that we need to be providing aggressive treatment to this patient, which also includes volume replacement on top of the epi and the Benadryl and what have you. Okay, so the metabolic states, as we discussed earlier, ketoacidosis. Well, ketoacidosis a lot of times is associated with some other type of perfusion problem as well, right? So we have a decrease in perfusion and we have a decrease in we have an increase in acidosis also, which actually decreases our end-tidal CO2 further. Okay, if we have increasing acidosis, especially with a lactic acidosis as well, we likely will have a decrease in carbon dioxide production just based on the situation. This is a lactic acidosis you may or may not be aware of, but when our body is working extra hard, we move from aerobic metabolism, aerobic meaning using oxygen, to anaerobic metabolism, which is where our body is no longer able to consume oxygen the way it was. And the byproduct of that, since the body is no longer able to produce as much oxygen and therefore create carbon dioxide waste, the body is then producing lactic acid to get rid of that additional acidosis that's accumulating in the body. Okay, so carbon dioxide production may actually be down because of an anaerobic metabolism, and lactic acidosis is the byproduct, which then that acidosis, whether it's actually keto or lactic, depending on the patient condition, has to be pissed out through the kidneys. Well, if a decrease in lung volume, or if we have a decrease in circulatory volume because of some profound hypoperfusion disorder, such as sepsis, that lactic acid will continue to build up, and then the body cannot get rid of it because of the lack of blood flow and fluid flow to the kidneys. So if we're suspecting a patient that is profoundly ill, either to diabetic ketoacidosis or due to sepsis, because septic patients will have, later on in the game, they'll have increased levels of lactic acidosis because essentially a sepsis patient, their body and their tissues and organs are being deprived of oxygen due to clotting of the microvasculature. So in the same way that someone runs a marathon and is going through the process of lactic acidosis, well, now we have a very, very sick patient who cannot recover from this anaerobic metabolism, and lactic acidosis continues to increase. Okay, so hopefully I covered that area thoroughly enough. Now let's go back down to looking at our whole reference chart here. And we were just over in this area here. And there are some cases where you may actually transition to this area here. Now, one of the most important ones that we can discuss is the asthma and COPD type patient, and then also our CHF type patient. Okay, and it's important for us to remember that with an asthma and COPD patient, we still have this bronchospasm, right? And a patient may actually be presenting to us like they're improving. Maybe we've given them a CombiVent treatment and they seem like they're getting a little bit better. And their respiratory rate has actually decreased to a normal level, and their end tidal level has actually increased to what is a normal level. Now, we on the surface, if we're not measuring with capnography in the beginning, middle, and end, we may actually think that since that work of breathing has gone down, this patient is actually improving. Now, if we're looking at just our end tidal levels, our numbers, then we're going to think that patient's improving as well. What may be happening is that the patient is actually getting worse. They're starting to struggle to breathe, may not be readily noticeable visibly, but what we might have is that ever increasing or sloping waveform. So early in the process, we may have a waveform that's slightly rounded, and then as the time goes on, even with respiratory rate improving and end tidal levels improving, we may actually have an increasing slope of carbon dioxide. Increasing slope of our waveform, which, remember, that is a further decrease in exhalation. Okay, it's a delayed exhalation, and that equates in this situation to bronchospasm. So the body is further restricting the amount of air expelling from the lungs. As that process continues, though, we'll continue to have the decreased respirations and a higher and higher trending carbon dioxide level. When that gets to be the case, we know we have a serious situation in our hand, and the treatment that we're providing thus far is not working. So we may need to be giving a second CombiVent treatment. Depending on the condition of the patient, we may need to give magnesium sulfate, as what a lot of people use. Maybe some people are still using epi, though there's a lot of contraindications to using epi in those situations for such as the asthmatic. I've done it before rather successfully prior to utilization of mag sulfate. But mag sulfate works great because it relaxes those bronchioles, and it's smooth muscle relaxant, so it really helps out great for those severe situations. So this is a great example where capnography is going to allow us to be more proactive instead of reactive. If we see a patient trending towards this area, okay, we can react much quicker, because if this patient starts getting up to 65 to 70 millimeters of mercury, you are probably going to have an impending respiratory arrest. Okay, not only is that patient not expelling air, they are essentially suffocating because of the restriction of air. And in some cases, they may actually be auto-peeping to where their alveoli, the pressure within our alveoli is so high that you would need to utilize some type of CPAP or PEEP to overcome that pressure to provide gas exchange. So you may actually have this patient that's getting so bad that their SpO2 is actually decreasing as well, okay, significantly. However, remember that's a bit of a delayed response. Remember, pulse ox is not a readily noticeable issue, so by far our end tidal levels are going to aid us the best, along with, in conjunction with our waveform analysis. This is a great example of evaluating our trends of our waveforms and our levels. Okay? Very important. Now, what about that pulmonary edema patient? We've got this pulmonary edema patient, or let's just say severe CHF. You have a patient who's responding, or you feel is responding to your treatment. You're providing CPAP at 10 centimeters of water. They seem to be working. You start providing nitro and maybe captopril if you have it in your protocol. You're treating them aggressively. You have a normal waveform, so you feel confident that even though that patient has a history of COPD, today's cause is CHF. So we can maybe not provide bronchodilators in a case where we are kind of taking a stab in the dark with one or the other. Okay, and the end tidal levels may be somewhat in the normal area to normal low, and respiratory rate will be increased either way. And then the patient starts getting worse and worse. As time goes on, remember, these patients are having trouble moving volumes of air because we have a significant increase in perfusion in the lungs because of that left-sided heart failure. So we have a backup of fluids coming into the lungs, which is causing this patient to essentially be restricted in the amount of air they can ventilate. So over the course of time, as they start failing, they're going to have a decrease in respirations. A lot of times, simply that may be one, partly because of the hypoxia, but two, because the patient just cannot work against what's going on anymore. Okay, so these patients will be progressing into respiratory failure, as I have here as well. Okay, and as that happens, the carbon dioxide levels will increase. Now, it's important to remember that the carbon dioxide levels may be increasing within the alveoli itself, where the gas is transferred. However, as this patient starts to go into respiratory failure, and ultimately to a point where their respiratory rate decreases significantly, you have a decreasing rate and you have a decrease in tidal volume. You may actually have a decrease in carbon dioxide because, well, they're stopping breathing. It then, of course, would not, air end tidal levels would not be accurate as compared to what's going on down in the circulatory portion of the body because you have a decrease in ventilation. And until you take over ventilations, you're not going to really get a true reading of what their carbon dioxide levels are because remember, ventilation, perfusion, and metabolism, all three need to be present in order for us to adequately measure end tidal levels. So these really are the two quadrants that we're going to be seeing things the most, but it's also it's also good to remember that we may actually have an intermixing of different quadrants, as I mentioned earlier before. You might have a hypermetabolic state that causes that dual VQ mismatch, or you also have a hypovolemic state causing that dual VQ mismatch. Okay, we don't have quite enough time to cover all of this today, as we're running a little long on time here as it is, and I want to keep your attention span going. So if you email me with a request, I can provide this chart for you, and that can better help you evaluate as you utilize capnography and treat your patients. So in closing today, a complete assessment is essential. We need to utilize capnography with our complete assessment, and the more you use it, the more you learn. The more you learn, the more you want to use it. Ventilation, perfusion, and metabolism, all three must be present for us to measure our end tidal carbon dioxide production. Okay, just as I just mentioned with that CHF patient who's failing, going into respiratory failure. If we're going into respiratory failure, we're not going to be able to adequately measure end tidal levels. Just the same if we had a cardiac arrest patient, but we weren't doing CPR, but we were ventilating. We're not circulating the carbon dioxide out through the lungs. Okay, and when we're evaluating the waveform, we're evaluating the numbers, we're evaluating the trends of both the waveform and the numbers. All great things to remember. Hopefully you learned something today. And if you need any further clarifications, feel free to contact me. For now, take care, and we'll see you later.